Chapter 31 Obstructive Pulmonary Diseases. Respiratory diseases are extremely difficult to both manage and live with. Think about what if you had to think about every breath you take? That's what most people live with when they have obstructive lung diseases. It's the most common chronic lung disease. All have increased resistance in airflow. And there are four types discussed in this chapter: bronchiectasis, cystic fibrosis, asthma, and chronic obstructive pulmonary disease, or COPD. Let's start with bronchiectasis. Bronchiectasis is a permanent abnormal dilation of the medium-sized bronchi due to inflammatory changes. They result in a destruction of the elastic and muscular structures of the bronchial wall, along with cyclical process of inflammation resulting in damage, causing remodeling, and also colonization of microorganisms that results in a weakening of the wall and pockets of infection and pneumonia. Here from figure 31.1 from our textbook, we have a longitudinal sectional of the bronchial wall where the chronic infection has caused damage in that top picture. For B is a collection of the purulent material within those dilated bronchioles. And C, we have that bronchiectasis in a patient with cystic fibrosis who underwent a lung transplantation. The bronchial wall injury damages the mucociliary mechanism that allows the accumulation of mucus and bacteria within the pockets. The bacteria attract neutrophils, which further increases inflammation and causes edema. This also results in an impaired clearance of mucus by the cilia, leading to stasis of thick mucus and a reduced mucus clearance and decreased expiratory flow rate. For the etiology, there could be many different causes. In 40% of cases, there is no known cause. Others are cystic fibrosis in children, bacterial lung infections in adults that can follow one episode of severe pneumonia, or from untreated, inadequately treated, or pneumonia treated that was delayed. Other risk factors include airway obstruction from mucus plugs, impaired pulmonary defenses, and repeated aspiration. Some of the clinical manifestations include hemoptysis, which can be severe and life-threatening. Also pleuritic chest pain, dyspnea, clubbing, weight loss, anemia, and adventitious breath sounds, including wheezing. Other complications include pulmonary hypertension, repeated exacerbations, often with chronic inflammation and hypoxemia, colonization with multi-drug resistant organisms, and a neovascularization, meaning the development of new blood vessels after that injury of those bronchial arteries that can lead to that hemoptysis and potentially even hemorrhage. For our diagnostic studies, a CT scan is the gold standard. They could also consider techniques such as a chest x-ray or spirometry, or even sputum cultures to confirm an infection. Unfortunately, there is no cure, and it's usually managed effectively on an outpatient basis. Our therapy goals are going to be to treat the acute flare-ups and prevent decline in lung function. We could also be using broad-spectrum antibiotics, oral, IV, nebulized for a minimum of 14 days, and depends on the culture results or the most probable organism. If given long-term, if symptoms recur within a few days, bronchodilators, such as, you'll see the term SABA up there, meaning short-acting beta agonist, and as soon as you see short-acting beta agonist, immediately just think albuterol. That's one of those terms where out in the field, everyone just uses and calls it albuterol. But your textbook, your ATI, you're going to see many other places try to call it a SABA, a short-acting beta agonist, just to stay away from the trade name. In cases of immediate distress, our priority is to maintain a patent airway, ensure adequate route for ventilation, stable vital signs, and notify the healthcare practitioner, especially if the patient is expectorating large amounts of blood. In cases of no immediate distress, make sure we're getting a good patient and family history, onset, risk factors, past complications, and current drug therapy and treatments, of which that short-acting beta agonist albuterol is going to be a top priority. We want to get that airway opened back up as quick as we can. Clinical problems may include activity intolerance, a deficient knowledge, with our goals of, again, maintaining that patient patent airway is top priority, along as having them slow, steady, unlabored breathing, and to develop a routine with as much functional independence as possible. For our patient teaching, we've got a healthy lifestyle. Quit smoking, at a minimum cut back. Also include things like a healthy diet, regular exercise, helping to prevent exacerbations and identify triggers, airway clearance techniques, and proper hydration to help thin out those secretions. Other symptoms to report include sputum production, dyspnea, hematitis of a moderate to large amount, and also monitor those expectorants for a spot of blood at times is expected, as well as monitoring for fever, chills, and chest pain that may or may not occur. Other interventions would include elevating the head of the bed to at least 30 degrees, monitoring vital signs, O2 therapy via the low flow device, place him in a side-lying position with the bleeding side down if any bleeding is expected, making sure to have oral suction available, and ensure a valid type and cross match in case of emergencies. Also, things like promoting drainage and removing mucus, chest physiotherapy, hydration of the respiratory system, good nutrition, and proper oral hygiene. For our evaluation, expected outcomes include maintaining a patent airway, normal respiratory rate and rhythm, a healthy balance between activity and rest with ADLs, and performing that optimal self-management and as much self-care as they can. Next, let's talk about cystic fibrosis. CF, or cystic fibrosis, is an inherited autosomal recessive genetic disorder with altered transport of sodium and chloride ions in and out of the epithelial cells. This results in an airway obstruction due to changes in the secretions, and this results in an increased heavy, thick mucus production. While primarily affecting the lungs, it does affect other areas of the body, including the GI system, such as the pancreas and biliary tract, and also the reproductive organs. There are about 30,000 people living with CF in the United States, with more than 50% of those as adults. The median age at diagnosis is about 6 to 8 months, with 2/3 of patients diagnosed in the first year of life, though some could not be diagnosed until adulthood. The severity and progression varies, with prognosis having improved with early diagnosis and new therapies, and a median predicted survival having increased to over 46 years. This is a major increase, as it was 16 years of age back in 1970. There's also a genetic link, as the autosomal recessive disorder found in the chromosome makes a protein called CF transmembrane. These mutations change the normal function of the protein. The channels in and out of the epithelial cells are then blocked, causing the cells that line the passageways of those lungs, pancreas, intestines, and other organs to make secretions low in sodium chloride and water content. This results in a mucus that's abnormally thick that plugs the ducts in these organs, causing scarring and even resulting in organ failure. As you can imagine, this has a serious, significant effect on the airways. Upper and lower respiratory tract manifestations include that mucus lining being dehydrated and tenacious from defects in the chloride secretion and sodium absorption. The cilia are then overwhelmed with thick secretions, allowing mucus to adhere to airways, and the bronchioles obstructed lead to scarring, air trapping, and hyperinflation of the lungs. The pathophysiology is a persistent, chronic, incurable airway infection. The most common organism cultured is Pseudomonas. Antibiotic resistance can develop after multiple exposures to antibiotics, and inflammatory mediators can also result in that progression. Initially, chronic bronchiolitis and bronchiectasis. As it progresses, pulmonary vascular remodeling occurs because of that local hypoxia, anteriolar vasoconstriction. That leads to pulmonary hypertension, enlarged arteries, and even cor pulmonale in later phases. Blebs and cysts in the lungs are severe manifestations of destruction. These complications include a pneumothorax or even hematitis that can be fatal. Within the GI tract and system, pancreatic insufficiency is caused by mucus plugs in the pancreatic ducts, resulting in atrophy and progressive fibrotic cyst formation. That endocrine function of the pancreas is altered or may be lost completely. Also, insufficient production of enzymes, lipase, amylase, and protease do not allow for the absorption of nutrients. This results in a malabsorption of fat, protein, and fat-soluble vitamins that can manifest as steatorrhea, or large, oily, frequent bowel movements, a failure to grow and gain weight, osteopenia and osteoporosis, or even pancreatitis may occur. Cystic fibrosis related diabetes may also occur and is related to the underdevelopment of the islet cells in utero and the later destruction of islet cells over the lifetime. And they could have both type 1 and type 2 characteristics, and making insulin too late to fully respond to any carbohydrate intake. They may also have GI problems related to GERD, gallstones, and cirrhosis. The mucus deposits damaging the liver along with the gallbladder, and other manifestations of portal hypertension, distal intestinal obstructive syndrome, and may appear to have small bowel obstruction. For our first case study, KW, a 31-year-old man with cystic fibrosis, visits a clinic for his annual physical exam. He is married and in good overall health. He has a cough with scant wheezes oscillated. Depending on the severity of the disease, it could vary greatly within families and among different families. Carriers do not necessarily have symptoms. Early manifestations that suggest CF include meconium ileus in the newborn, acute or persistent respiratory symptoms, failure to thrive or malnutrition, steatorrhea, bronchiectasis, or family history. An atypical presentation in adults includes diabetes, infertility, and commonly seen frequent cough that becomes persistent, producing thick, purulent sputum. Other upper respiratory infection manifestations, such as chronic sinusitis, nasal polyposis, recurring lung infections, and clubbing. Exacerbations increase in frequency, resulting in increased cough and sputum, weight loss, decreased lung function, and eventually results in total respiratory failure. These patients may also see delayed puberty. In females, menstrual irregularities, amenorrhea, difficulty conceiving, and most are able to conceive have viable infants. For males, the vas deferens doesn't develop. They do make sperm normally and are able to father a child with assisted reproductive technology. KW states that he and his wife are thinking of starting a family. He asks what the chances are of transmission of cystic fibrosis to his children. Beginning with the reproductive side, it may take special procedures for them to conceive. His life expectancy may be less than hers related to that cystic fibrosis, and consider that the child will be a carrier or possibly have the disease. Other complications include cystic fibrosis renal disease, bone disease, sinus disease, liver problems, pneumothorax being rare but serious, as well as the hemodialysis, liver failure, and other late complications such as respiratory failure and cor pulmonale. The gold standard in identifying cystic fibrosis is the sweat chloride test. Genetic testing done as results from sweat chloride tests are uncertain. They can't send blood or small cell samples specially to the lab. Most lab test only for the most common mutations of the CF gene, though. There are more than 1,700 mutations that could cause CF, making screening difficult. His primary care provider refers KW to a new CF care center in his city. The patient asks what this center will be able to provide for him. One such center would be Cystic Fibrosis Foundation, with more than 1,200 CF care centers nationwide. They work to improve the length and quality of the patient's life, as well as the best care, treatment, and support. The team includes physicians, nurses, nurse practitioners, respiratory therapists, physical therapists, social workers, and a dietitian. Management focuses on relieving airway obstruction and controlling the infection. Aerosol and nebulizer treatments promote drainage of thick bronchial mucus plugs and dilate the airways, liquefy the mucus, and promote clearance. Other interprofessional care would involve the airway clearance techniques, working to loosen mucus, along with chest physiotherapy and postural drainage, percussion, and vibration. This is a technique that uses high-frequency chest wall oscillation systems to help really shake loose that mucus and help the patient move and expel it. Unfortunately, most patients with CF die of complications from lung infection. Early intervention with antibiotics is key. The choice of antibiotics based on the spectrum culture results. 2 antibiotics with different mechanisms of action are usually used together to prevent it growing resistant. And drugs are abnormally metabolized and quickly excreted, may need prolonged high-dose therapy. Adequate home support and resources is key, along with that IV antibiotic therapy at home. We want to manage mild exacerbations with oral agents and be on a close lookout for infections such as Pseudomonas, which is difficult to treat as the organism forms a biofilm that protects it from antibiotics. These patients may also require home O2 therapy in the cases of cor pulmonale or treating hypoxemia. In the case of pancreatic insufficiency, we're going to replace the pancreatic enzymes and supplements, along with increasing the diet adequate fat, calories, and vitamins, especially A, D, E, and K. These patients may also get caloric supplements, added dietary salt with increased sweating, and insulin if hypoglycemia develops. You may see a lot of pancreatic enzyme questions come up on ATI and NCLEX a bit. In this case, it's going to come in a lot of different varieties. In the case of capsules, they'll sprinkle the pancreatic enzymes onto their food. And it's just supplemental pancreatic enzymes to help them digest that they take along with their meal. In the case of distal intestinal obstructive syndrome, we're going to consider options such as prokinetic agents, mucolytics, stimulant laxatives, lactulose even, along with careful monitoring of their bowel habits and patterns. In extreme circumstances, surgery may not be successful, and we want to really work to prevent ischemic bowel. We want to include genotyping done for all patients to determine if they carry a mutation that is a target for cystic fibrosis modulator therapy. Our assessment would include both subjective and objective data, along with impaired respiratory function, nutritionally compromised, and deficient knowledge, clinical problems, and nursing diagnoses. And when planning to meet our overall goals, we want to make sure we've got adequate airway clearance, absence of respiratory infection, adequate nutrition to maintain appropriate weight, ability to independently or with assist perform ADLs, recognize and treat complications related to CF, and actively take part in planning and implementing the treatment plan. What questions would you want to ask KW about his health in the past year? What about within the last month? Also, KW states that he has some difficulty with increased cough and sputum in the morning. He also has difficulty coughing up that sputum due to its thickness. For acute care, our goal is the relief of bronchoconstriction, along with airway obstruction, airflow limitations. We're going to do that through aggressive chest physiotherapy, antibiotics, and oxygen. We also really want to focus on that optimal nutrition as well as hydration to try to keep those secretions thinner and easier to expel. KW states that he and his wife want to begin an exercise program. He asks what type of exercise might be best and if he needs to consider anything special related to his cystic fibrosis. For our ambulatory care, aerobic exercises can be effective in helping to clear the airway. Also, again, with that increased nutrition, observing for dehydration, maintaining high fluid intake, and replacing the lost salt. We also want to work to facilitate the patient's ability to assume responsibility for their own care. As much care and treatment the patient can provide to themselves, the better, more independent, and the better they are prepared to manage their condition. This patient could also face many difficulties going through life, everything from employment, motivation, coping, dependence on others to help deal with their condition, as well as financial needs, and pointing them to the appropriate community resources as well as the Cystic Fibrosis Foundation. Moving on, let's talk asthma. Asthma is a diverse disease characterized by bronchial hyperactivity with reversible expiratory airflow limitations, whether spontaneously or as a result of treatment. In the case of minor asthma, the patient would have minor shortness of breath and chest tightness. In major asthma attacks, the patient's going to have severe shortness of breath, as well as accessory muscle use, stridor, severe hypoxemia, leading to respiratory and/or cardiac arrest if left untreated. Asthma affects around 25 million Americans each year, with more than 2 million ED visits, 10 million outpatient visits, and 500,000 hospitalizations. Mortality rates have been decreasing over the past 10 years, though there are still more than 4,000 people who die of the condition each year. There can be some gender differences with asthma. In men, it typically affects more boys before puberty, and is more likely to have less severe symptoms by late teen years. For females, it affects women in adulthood, with higher incidence and severity among 40 to 60 years of age. They're more likely to need hospitalizations if they come to the ED, and also have a higher mortality rate. It can also have a wide array of triggers, both genetic factors as well as environment, such as pollen and other triggers. Other triggers could be nose and sinus problems, such as a history of allergic rhinitis, and the treatment usually improves these symptoms. There could also be acute and chronic sinusitis that might make the asthma worse, and this would involve inflammation of the mucous membranes that can precipitate an asthma attack and need to treat these large polyps that need to be removed. Allergens can cause varying degrees of allergic reactions. It's not clear about the role in development of asthma, whether it's indoor and outdoor allergens, everything from cockroaches, furry animals, fungi, pollen, molds. For triggers, you may also see NCLEX and ATI bring up things like hanging pictures on the wall or those blinds over windows, anything that could collect dust and provide that trigger. Another trigger could be cigarette smoke, with it estimated that 21% of people with asthma do smoke. It results in a faster decline in lung function, increased severity, more visits to the healthcare provider, and a decreased response to treatment. Other environmental tobacco smoke risk factors include passive smoking or secondhand smoke. Other pollutants that could trigger an asthma attack include wood smoke, vehicle exhaust, working in heavily industrialized or densely populated areas, and climate conditions such as thermal inversions or stagnant air masses. Also, ozone alert days, in which patients with breathing problems should minimize outdoor activity. Respiratory tract infections could also be a major trigger of acute asthma attacks. Upper respiratory infections decrease the diameter of the airways and induce airway hyperresponsiveness. These also contribute to altered respiratory function and worsen the asthma. There is an hygiene hypothesis related to asthma, in which newborn and child's immune systems will not fully mature and develop in extremely clean environments. Exposure to different germs and various infections during infancy and childhood could help to strengthen their immune system. The genetic component is complex, as it's likely responsible for different responses to triggers and asthmas and drugs. Another major risk factor is atopy, the genetic predisposition to develop an allergic response to common allergens. GERD is another trigger that's more common in people with asthma. The reflux may trigger bronchoconstriction as well as cause aspiration. Asthma medications may worsen GERD symptoms, and treating the GERD can improve nocturnal asthma control, improve their quality of life, as well as prevent asthma symptoms. Drugs and food additives may also be a trigger. Everything from asthma triad, those nasal polyps, asthma, and sensitivity to aspirin and NSAIDs. The salicylic acid and NSAIDs must be avoided, and unfortunately they're found in many over-the-counter drugs, foods, beverages, and flavorings. Teach the patient to read labels, and they may want to improve with desensitization, that is, the daily administration of the drugs under the care of an allergist. One major drug you'll see come up a lot with asthma is the use of beta blockers. Beta blockers are contraindicated in patients with asthma because these are drugs that can cause bronchoconstriction, which is the last thing we want with a patient with asthma. Other cardiac meds such as ACE inhibitors that can cause that dry hacking cough. Tetrazine, the yellow dye number 5, and sulfite agents, that's a common additive to food. And food allergies triggering asthma reactions in adults should be carefully monitored. Exercise can be another major trigger to asthma, in that asthma is induced or becomes worse during that physical exertion. It can also be compounded by activities in cold, dry air, as the airway obstruction can occur with changes to the mucosa from hyperventilation, inhaling cool or rewarmed air, and airway edema. This exercise-induced bronchospasm often occurs within less than 10 minutes of vigorous exercise and will resolve within 60 minutes. Occupational asthma is another consideration, the most common job-related respiratory problem, and this would include exposure to things like wood dusts, laundry detergents, metal salts, chemicals, paints, solvents, and even plastics. Asthma can also be triggered and worsened due to stress, as asthma attacks can cause panic, stress, and anxiety. This extreme behavioral expression, such as crying, laughing, anger, and fear, can also lead to hyperventilation and hypocapnia. Moving on to another case study. AD, a 30-year-old woman, comes to the emergency department with severe wheezing, dyspnea, and anxiety. She recently had a cold that did not resolve. She is upset that her children had just brought home a stray cat. She does not know if she is allergic to the cat. The main pathological process is persistent and variable inflammation of the airways. And exposure to these allergens or irritants triggers that inflammatory cascade, causing the airway inflammation. Here in our figure from 31.3 from the text, it just shows the process, beginning with the triggers and the activation of the immune response and inflammatory process upon the airways. An early phase response occurs within minutes after exposure to an allergen or irritant, and generally resolves within 1 to 2 hours. Symptoms can recur 4 to 6 hours later due to an influx of inflammatory cells, and mast cells that release inflammatory mediators when an allergen cross-links with IgE receptors. These mediators include leukotrienes, histamine, cytokines, prostaglandins, and nitric oxide. Here we also have figure 31.4 from the text, and it shows an allergic reaction that's triggered when an allergen cross-links IgE receptors on mast cells, which are then activated to release histamine and other inflammatory mediators. These inflammatory mediators affect blood vessels, such as vasodilation, increased capillary permeability, nerve cells, resulting in the itching, smooth muscle cells, resulting in that bronchial spasms and narrowed airway, and goblet cells, responsible for mucus production. From figure 31.5, factors causing expiratory obstruction in asthma. In figure A, we show that cross-section of the bronchiole occluded by a muscle spasm, edema of the mucosa, and mucus in the lumen. And then in B there, we see that longitudinal section of the bronchiole. In a late phase response, airway inflammation occurs within 4 to 6 hours after an initial attack due to the body's activation of more inflammatory cells. This occurs in about 50% of patients with asthma. The bronchoconstriction with symptoms can last for 24 hours or longer, and corticosteroids are used to treat and help prevent this inflammation. AD has been in the emergency department for 2 hours. She's now breathing a little easier and wants to go home. What are some questions we should consider, such as how long does she need to be monitored? What does she need to know before going home? And who else needs to be taught about her condition? In the case of remodeling, this is the structural changes within the bronchial wall from chronic inflammation. Changes include fibrosis, smooth muscle atrophy, mucus hypersecretion, angiogenesis, and continued inflammation. The progressive loss of lung function, not fully reversible, results in persistent asthma, and the remodeling and genetic factors help explain why some have persistent asthma and limited response to therapy. Characteristic manifestations of an asthma attack include wheezing, cough, dyspnea, and chest tightness. Hyperinflation and prolonged expiration due to air trapped within those narrow airways as well. Within an acute attack, you'll see wheezing being the most common hallmark symptom, as well as initial expiration and, with progression, both inspiratory and expiratory wheezes. Wheezing is an unreliable gauge of the severity of the attack, and the patient must move enough air to make the sound. Mild attack may have loud wheezing, whereas a severe attack, the wheezing with forced expiration could be not audible at all due to the severity of the closure and constriction. Decreased or absent breath sounds may occur due to exhaustion and an inability to have enough muscle force for breathing. That silent chest is an ominous sign, and severely decreased breath sounds, severe airway obstruction, or impending acute respiratory failure, which is life-threatening. Hyperventilation from the increased lung volume from trapped air and limited airflow. This results in abnormal alveolar perfusion and ventilation, causing the patient to be hypoxemic with an increased pH or respiratory alkalosis that results in respiratory acidosis as the patient tires and is an ominous sign for acute respiratory failure. In cough variant asthma, cough is the only symptom, as well as bronchospasm, not severe enough to cause airflow obstruction or wheezing, and can increase bronchial tone, cause irritation, and stimulate cough receptors. May be non-productive or productive with thick, tenacious gelatinous secretions that make removal difficult. AD continues with her wheezing. Her anxiety increases. What other signs of hypoxemia would you assess for? For asthma classifications, there are several sets of national and international guidelines that exist that vary slightly on how to classify the severity of an asthma attack. The severity is used to guide treatment decisions, as these guidelines focus on assessing severity at diagnosis and initial treatment, include periodic monitoring to control the disease, endorse stepping up or stepping down medications, have an action plan to help prevent future attacks, and include patient education and adherence. GINA, the Global Initiative for Asthma, is the most widely recognized guidelines. And the 2012 NIH National Heart, Lung, and Blood Institute, used by many healthcare providers to classify the asthma severity and describe asthma as intermittent, mild, moderate, and severe. AD is diagnosed with intermittent asthma. It's probably exacerbated by an allergic response to the cat. What other assessment findings would you anticipate? Asthma attacks range from minor to life-threatening and last a few minutes to hours, and also include that airway remodeling we previously discussed that predisposes the patients to pneumonia, worse episodes of flu, and even a tension pneumothorax. Status asthmaticus. This is a life-threatening medical emergency, the most extreme form of an acute asthma attack, and is characterized by hypoxia, hypercapnia, and acute respiratory failure. Bronchodilators and corticosteroids are not effective at opening the airway back up. The chest tightness, severely marketed increases in shortness of breath, and a sudden inability to speak. Without treatment, this leads to hypotension, bradycardia, and respiratory or cardiac arrest. Emergency treatment would include IV magnesium sulfate, immediate mechanical ventilations, hemodynamic monitoring, analgesia and sedation, as well as neuromuscular blocking agents and inhaled anesthetics. You perform a detailed assessment on AD. She reports that she is a beautician and that she smokes about a half a pack of cigarettes a day. Within our detailed history and physical exam would include previous attacks, and also differentiating from other disorders with wheezing and cough. Also peak expiratory flow rates, such as the test of the lung function. This is performed at home or in a healthcare setting, and measures the patient's maximum rate of airflow after forceful exhalation. This helps predict asthma attack as well as monitoring the severity of the disease. Spirometry may also be used to assess lung volumes and capacities. Remember to stop bronchodilators for 6 to 12 hours prior to the test. And the reversibility of obstruction following bronchodilators is important for diagnosis. Other assessments may include the fraction of exhaled nitric oxide. In this case, increased levels of eosinophilic-induced inflammation, and can be used to gauge the loss of asthma control in attacks, as well as the patient's adherence to therapy and determine the need for more anti-inflammatory medication. This could also be combined with other things such as allergy testing, chest x-rays, and a sputum culture to rule out bacterial infection. The goal of treatment is to achieve and maintain the control of their asthma symptoms, and following medication guidelines based on steps such as symptoms worsened, step up medication, symptoms controlled, step down medication. Here in figure 31.6, we have the stepwise approach to asthma treatment. This is modified from the GINA evidence-based strategy document. AD has intermittent asthma. Based on this diagnosis, she'll be treated at step 1, as she was treated in the ED with a nebulizer treatment. A patient is admitted to the emergency department with a severe exacerbation of asthma. Which finding is most concerned to the nurse? A. Unable to speak and sweating profusely. B. A PaO2 of 80 and a PaCO2 of 50. The presence of inspiratory and expiratory wheezing. Or D. Peak expiratory flow rate of 60% of personal best. That answer is going to be A. Unable to speak and sweating profusely, as this patient is unable to move hair. During a severe exacerbation of asthma, the patient may not be able to speak, or may speak in words, not sentences, because of difficulty breathing. The patient may also be perspiring profusely. Other indicators of severe asthma include an absence of wheezing. Because of that limited airflow, they're not moving enough air to cause that high-pitched whistling sound. It has a complex treatment, as asthma drugs are divided into two general types: short-term control or rescue agents to treat attacks, or the preferred reliever agents that prophylaxis to prevent attacks. Also, a history and frequency, severity of attacks is important in choosing the type of drugs used. Inhaled corticosteroids are a first-line agent, used in an acute attack as a first step in acute asthma management. They are most effective for short-term control of asthma. Unfortunately, these drugs do have side effects such as easy bruising, decreased bone mineral density, oropharyngeal candidiasis, hoarseness, a dry cough, and reduced or prevented by using a spacer with a multi-dose inhaler. Maybe even consider gargling with water or mouthwash after each use as well. Would be especially beneficial in preventing that candidiasis. Next, as we talked about previously, albuterol, or SABA's short-acting beta-adrenergic agonist. I know a lot of you are LPNs here in the room, and you're probably very familiar with albuterol and give it a lot. When you see short-acting beta agonist, SABA's, they're talking about albuterol. It's no longer a first-line therapy in acute attacks. That's going to depend by facility, but they do have a key role in the management. They stimulate those beta receptors in the bronchioles to reduce bronchodilation. They also increase mucociliary clearance, have an onset within minutes, and a duration of 4 to 8 hours. These short-acting beta agonists prevent the release of inflammatory mediators from mast cells. Though keep in mind, too frequent of use can cause tremors, anxiety, tachycardia, palpitations, and nausea. They also indicate poor asthma control and may mask the severity of the condition. Next would be LABAs, or long-acting beta agonists, such as salmeterol you may be aware of. And it's used only as an adjunct to treatment. It's not to be used alone as a primary treatment, and not for acute symptoms or quick relief from a bronchospasm. This is not a drug to be used in emergencies. It's more of a long-term prophylaxis or prevention. Methylxanthines are sustained-release preparations and are not first-line controlled medications. An example of this would be theophylline. It's a weak bronchodilator with mild anti-inflammatory effects. It's no longer recommended by JANA and used only as an alternative. Many drug interactions and side effects may take place with this medication. Next would be anticholinergic drugs such as ipratropium, and these promote bronchodilation by preventing muscles around the bronchi from tightening. While they're less effective as SABAs, you may see ipratropium given with albuterol a lot. If you ever hear the term duo-neb, that's what they're referring to, is the combination of albuterol and ipratropium within the nebulizer. Next would be leukotriene modifiers. These are inflammatory mediators and are potent bronchoconstrictors. Some cause airway edema or inflammation and a worsening of an asthma attack. Leukotriene receptor antagonists block the release of some substances from mast cells and eosinophils, and produce bronchodilator and anti-inflammatory effects. They do not reverse bronchospasm in acute attacks, and unfortunately they are less effective than corticosteroids, used only as an adjunct therapy when there has been no response to other treatment. 1 month after discharge, AD returns to the ED with an acute exacerbation of her asthma. IV corticosteroids are given in the ED, and an inhaled corticosteroid is prescribed for daily use. Anti-IgE, or Xolair. This reduces circulating free IgE levels and prevents the IgE from attaching to mast cells, preventing the release of chemical mediators. This is for patients with moderate to severe asthma or those not controlled with corticosteroids alone. Unfortunately, it also does come with a risk of anaphylaxis. Anti-interleukin 5, Nucala. This inhibits interleukin 5 to inhibit the production and survival of eosinophils, and is used with severe asthma attacks as an adjunct to other medications. Other non-prescription combination drugs would be things like ephedrine and guanfacine. These are over-the-counter drugs that also should have many side effects. Epinephrine and ephedrine inhalers stimulate the central nervous system and could be potentially dangerous. Teach patients about the dangers, especially with patients for underlying heart problems, and advise them to consult with their provider if they insist on taking them. Inhalation devices for drug delivery. Many asthma drugs are given by inhalation, because this has a faster action with fewer systemic side effects. Many of these devices include metered dose inhalers, dry powdered inhaler, and a nebulizer. Metered dose inhalers are small handheld pressurized devices. They deliver at a measured dose with activation, 1 to 2 puffs, and can be used with a spacer or holding chamber to reduce oropharyngeal medication deposition, increase the delivery to the lungs, and reduce problems with hand-breath coordination. Here we have our patient using their metered dose inhaler with that spacer chamber. Teach the correct technique in care, including taking several meter dose inhalers leads to confusion. Make sure the patient knows what each one is when they're supposed to take it. And we're going to do this through providing effective education and reviewing the use and techniques with each visit. Here in figure 31.9 from the text, we just have those written instructions on how the patient should use their metered dose inhaler correctly. AD is being discharged from the ED after her exacerbation. She's had difficulty with the administration of her metered dose inhaler, and a dry powder inhaler is now ordered. Dry powder inhalers are simpler to use than metered dose inhalers, and they provide a powdered medication and are breath activated. The advantage is there's less manual dexterity required, and no need to coordinate the device puffs with inhalation. Though disadvantages are inadequate inspiration. Not all common medications available as dry powdered inhalers, and the powder may clump if exposed to humidity. Here from figure 31.10 is just an example of that dry powdered inhaler. Both systems do provide equal efficacy, and it's just going to vary by patient. The costs can also vary wildly. Help select devices that best fits each unique patient needs. Next would be nebulizers, everybody's favorite. These small machine that converts drug solutions into a fine mist for inhalation via a face mask or mouthpiece, and are very easy to use. Patients with severe asthma or difficulty with metered dose inhaler inhalation may be given this route. They do not provide better delivery of medication than a spacer with an inhaler. They require air compressor or O2 generation. Make sure to provide education for techniques and care. An order must include the drug, dose, diluent, and whether they're nebulized with compressed air or O2. When giving a nebulizer, the patient must be in the upright position. Breathe slowly and deeply through the mouth, and hold each inspiration for 2 to 3 seconds. They should breathe normally in between, and cough effectively after treatment. When assessing an asthma patient, we want to get a detailed health history if the patient is not in distress, such as when the condition first diagnosed, what were the triggers, and what has worked in the past to relieve these attacks. For our clinical problems and nursing diagnoses would be impaired respiratory function, activity intolerance, anxiety, and deficient knowledge. Our overall goals would include having minimal symptoms during the day and night, maintaining acceptable activity levels, including exercise, have few or no adverse effects of drug therapy, no acute asthma attacks, and have an adequate knowledge to carry out their treatment plan. For health promotion, teach the patient to identify and avoid known triggers and irritants. Wash bedclothes in hot water or cooler water with detergent and bleach. Use scarves or masks for cold air. Avoid aspirin and NSAIDs, and consider desensitization therapy. Other health promotion may include evaluating the job environment, such as a job with a lot of dust, wood dust, particles in the air, and also helping them with weight loss and exercise. For acute care goals, achieve rapid control of the symptoms and return to the previous level of functioning as quickly as possible. During an acute attack, identify the severity and determine treatments such as signs and symptoms, medication use, and that the therapy is tailored according to the patient's history, severity, symptoms, and frequency of exacerbation. For mild to moderate asthma attacks, these are attacks that occur no more than 2 times a week, have minimal interference in their day-to-day activities, and the patient remains alert, oriented, speaking in sentences, though they may have chest tightness, varying levels of shortness of breath, and a slight increase in the use of asthma drugs. These mild to moderate asthma attacks may be treated with inhaled corticosteroids. In this case, we need to make sure we're monitoring their vital signs and expect rapid improvement, as well as the condition to slow or not responding to treatment or another condition is expected. We need to make sure we're transferring them to an acute care facility before it could deteriorate further. A severe acute asthma attack. This will be often very frightening, and it's going to depend on correcting the hypoxemia, continually observing and improving the ventilation. The patient may have tachycardia, tachypnea, tunnel vision on breathing, over 30 breaths a minute, with the use of accessory muscles to breathe, along with agitation, restlessness, and confusion. The patient often sits forward to maximize that diaphragmatic movement and try and move as much air as possible. Bedside peak expiratory flow rates to monitor airflow obstruction may not be possible during a severe attack. Severe obstruction is seen with a peak expiratory flow rate of less than 200 liters a minute, or 50% or less of predicted or personal best. For O2 therapy, we want to achieve a PaO2 of at least 60, with O2 saturations greater than 90%, and monitor continuously with pulse oximetry. In the case of severe acute asthma attacks, we want to give drugs as ordered, including oral corticosteroids if the patient can swallow, IV if not, short-acting beta agonists, albuterol, and usually symptoms gradually diminish but often reoccur. For us as nurses, we want to make sure we're auscultating lung sounds and hope for increased breath sounds and decreasing wheezing. That silent chest, again, is an ominous sign. That means that they are not moving air. For these severe acute asthma attacks, an important goal is to decrease patient anxiety and their sense of panic. Position them comfortably using semi to high Fowlers and within a calm, quiet, reassuring attitude. Gain eye contact, use firm, calm voice to coach the patient to use pursed-lipped breathing, and stay with the patient until the respiratory rate has slowed. When the attack subsides, encourage rest, provide quiet, calm environment, and when the patient begins to recover, try to obtain a history, such as their triggers, what happened, and perform that physical assessment. For ambulatory care, the major goal is to maximize the patient's ability to safely manage an acute attack using an asthma action plan. That asthma action plan would include the patient caregiver teaching, drug therapy, and monitoring for the control of symptoms. Review that asthma action plan frequently with the patient. Within the asthma action plan, green, yellow, and red zone meaning and management. For the green zone, that is 80 to 100% of their personal best, and continue the current drugs. For the yellow zone, that's 50 to 80% of their personal best, and we need to start looking at them closely, using caution. And within the red zone, that's less than 50% of their personal best. Notify that healthcare provider ASAP. Step up and down medication plan, and note where the patient's medications are kept. We also want to help the patient to develop an exercise program within their level of tolerance, including medication pre-treatment if necessary. This combined with good nutrition, uninterrupted sleep, and fluid intake of at least 2 to 3 liters a day. AD's husband is with her in the ED and preparing to take her home after discharge. They both express concern about exacerbations and knowing when to come in for help. Patient teaching related to the drug therapy would include understanding medications and how to take them and have a significant role in making asthma management successful. The frequent reinforcement is important for understanding the often confusing and complex medication therapy for asthma. The medication name, purpose, dose, method of administration, and when to use, as well as the difference between controller, preferred reliever, and alternate reliever drugs. Also, things to think about would be teaching the patient how to prime, use, and clean devices. Suggest a journal for symptoms and medication use to identify patterns. And consider the patient's ability to correctly use inhalers, such as their age, dexterity, cognition, affordability, convenience, administration time, and preference. And refer to the social services for socioeconomic factors impacting their access to resources and care. For evaluation and expected outcomes, maintain the patent airway with removal of secretions, have normal respiratory rate, unlabored breathing, and adequate breath sounds. Also, report decreased anxiety with increased control of breathing and correctly using medications. And again, manage that asthma and acute asthma attacks with that written asthma action plan. Anyway, due to the length of this chapter, I've broken it up into 2 parts, so I'll see you next in part 2.